Hi there. Welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and our program is one of surgical pathology slide review and interesting cases. I appreciate you joining me as we talk about today's case, which comes from the realm of GI pathology. The patient is a 61-year-old man who has been found to have a what seems to be a perigastric mass, and there looks to be omental involvement and possibly adrenal involvement, either directly or otherwise. I don't have a radiograph to share with you, but there was no defined pancreatic mass per se, although, as you know, sometimes perigastric tissues and the pancreas can sometimes become obliterated. So it's important in this particular kind of location to think about the things that live nearby the stomach. While this might be a primary gastric neoplasm, such as a GIST, you've also got the spleen nearby, and so benign and occasional malignant lesions from the spleen could be presenting in this sort of a manner. Although peritoneal spread would be a little bit unusual with most splenic lesions, unless it was a case of post-traumatic splenosis or something of that sort, where the spleen was becoming hypertrophic and perhaps you had an accessory lesion going on. We're also close enough to the retroperitoneum that the possibility of a liposarcoma, the well-differentiated variety, could be presenting in this type of a location. Pancreatic tumors, although often easily localized using modern scanning techniques, can occasionally become a bit obscure when the connection to the pancreas is less obvious. And that applies for some of the pseudotumors, inflammatory lesions that can go along with that. The adrenal is an uncommon cause of a perigastric mass, but does live near enough by that direct spread or enlargement from an obliterated adrenal would be a possibility. And then, of course, things that you don't usually think about, like lymphoma, inflammatory myofibroblastic tumors, or other mesenteritis type of lesions could also present in this location, along with the ever constant possibility of a metastasis. So here's a view of the low-power needle biopsy, which is obtained using endoscopic ultrasound. You can see there's a fair bit of necrotic debris and sheets and clusters of cells that appear to be cohesive. As we look a little further, you can see that there's a bit of vasculature to this, but there's broad zones of necrosis, and then this somewhat organoid, fairly uniform population of cells without real good gland formation per se, at least in the sort of macro sense. We have a few colonic glands here nearby. As we hone in on a little higher magnification, I think we can begin to see that there's maybe a little bit of a lattice-like pattern or a lace-like pattern with small little areas of tumor cells admixed with the obviously richly hemorrhagic background of the tissue area. And at higher magnification, you can see that, again, there seems to be a little clustering around a central microlumen or central acinus, perhaps, that gives this tissue a somewhat rounded and organoid pattern. So this is something that we might see with a neuroendocrine tumor. We might see with solid pseudopapillary tumors arising in the pancreas, or possibly even an Acinar-based tumor as well. So that would form initially the main considerations. But along with that, because the nuclei seem fairly uniform, there's abundant amphiphilic cytoplasm, we might think about adrenal neuroendocrine lesions such as paraganglioma or even an adrenal adenoma at times. Here's the highest magnification view, and we can see a little bit more of the nuclear detail here. A mild pleomorphism in size and shape, but generally centrally located, somewhat granular appearing pink cytoplasm, and no prominent nucleoli, so no macronucleoli. Maybe a mitosis or two in a few areas here. We can see one there. And so it certainly fits the description of a proliferative neoplasm in this setting. And then here we can see again very mild pleomorphism, and then this loose vasculature in the background, but mostly just broad sheets of cells with that slightly acinar type of architecture. Again, diffuse chromatin, very potentially neuroendocrine-like in this appearance, but not much in the way of nuclear molding. Maybe a mitosis here. So the workup that we proceeded with based on those considerations included some neuroendocrine markers. Any of these would be possibilities. Solid pseudopapillary tumor, we did do beta-catenin, pan-CK as well, and then chose the most available of the actinic cell carcinoma markers, trypsin, as well as including potentially calretinin and inhibin on the off chance that this is an adrenal medullary or a cortical type lesion. So here's the synaptophysin, which, as you can see at low magnification, is pretty well dead negative. There's a little bit of non-specific staining in the more serum plasmoid or serum plasma areas, as you see up here. But by and large, these cells are really not capturing that marker at all. In contrast, very characteristic pattern, as you see here with trypsin. And by very characteristic, I say there seems to be this accentuation around these little areas of acinus formation, as you can see here, little clear spots with generally granular cytoplasmic type staining that is incomplete, not strong throughout the cytoplasm, but certainly strong in areas of the cytoplasm. Here at higher magnification, we can see it's not involving the nuclei at all. And we can see these areas of accentuation around areas where the cytoplasm is abutting the potential acinar lumen or that sort of central space. And then here again, higher magnification, you can see the nice granularity to this staining within the cytoplasm, sparing the nucleus and some of the other areas. So other results, just to remember, of course, the pan-cytokeratin was positive, S100 was negative, beta-catenin showed only cytoplasmic staining. And although beta-catenin is not specific for solid pseudopapillary tumor, it certainly can be seen also in acinar carcinoma on occasion, less than 10%, but on occasion. And then chromogranin was also negative. So we arrived with the diagnosis of acinar-like carcinoma, presumably from the pancreas. And this is a tumor that is generally more frequently encountered in men. And usually these are adult men on towards the older spectrum, age spectrum. But it can occur over a very broad age range. And so you do have pediatric cases and so forth. It's only a very small percent of pancreatic neoplasm. So the likelihood that you're going to see one depends greatly on how much pancreatic pathology comes through your laboratory. In some cases, these have been quite bulky with a sort of exophytic growth pattern growing out and away from the pancreas, seemingly. And that's why the identification as a primary pancreatic neoplasm sometimes is complex. But occasionally they will actually grow in an intraluminal or intraductal pattern, which can therefore mimic IPMN or other types of epithelial pancreatic carcinomas. But the usual mutations that we would see with ductal carcinomas, KRAS or SMAD and so forth, those are not seen ever in this lesion. While in contrast, you may have BRAF, RAF1 or RET mutations. And in a small percentage of cases, you can also or can instead see the APC gene or CTNNB1 genes mutated, which may correspond to either Lynch syndrome or potentially Gardner's syndrome. Other sorts of heritable types of carcinoma can be associated with this. So our final diagnosis was acinar carcinoma or actinic cell carcinoma, presumably from the pancreas. Hope you enjoyed that little discussion and that you'll be more attuned to pick up those lesions the next time one happens to cross your desk. I thank you for joining our program and certainly encourage you to subscribe so you'll catch new releases, as well as feel free to communicate with me if you have questions comments or other ideas you'd like to share. I'm always open to and welcome your comments. And I'm pleased generally to have enough time to respond to most of them. So until next time, thanks so much for joining me.